Hello everyone, presenting a video that demonstrates the role of a high-flow cerebral bypass surgery in management of a complex left paraclinoidal internal carotid artery aneurysm. A 28-year-old female presented with left-sided vision loss for the past 3 months. The digital subtraction angiogram showed a complex, large left paraclinoidal aneurysm. There were multiple aneurysms arising from the lateral aspect, from the medial aspect, and from the dorsal aspect of the internal carotid artery. Though this patient passed the balloon occlusion study, however, the PET scan showed relative hypoperfusion in the left MCA territory. That showed that there was an element of misery perfusion in this patient, which was clinically dominant. The treatment options that were considered for this young lady was number 1, endovascular flow diverter replacement, and second, a surgical high flow bypass utilizing the radial artery as an interposition graft and connecting this graft to the external carotid artery in the neck and anastomosing into the middle cerebral artery, which would be later followed by a parent vessel occlusion performed with endovascular means. The idea behind a high flow bypass system was to provide as an insurance in case of reduction in the cerebral blood flow that may manifest clinically following the endovascular occlusion of the parent vessel. Point in favor of a flow diverter was that it was a relatively non-invasive method and it carried comparatively lesser morbidity rate. However, the points against the flow diverters were that it required the patient to be on dual antiplatelet agents for lifelong. This means that there would be an element of risk of bleed, and also, as she was young, there were concerns regarding the usage of antiplatelets with the pregnancy. Secondly, the symptom control with a flow diverter would obviously take a longer time, and non-obliteration and retreatment is a risk in 10 to 15% of such patient. And also, if this patient has APT resistance, then she is prone to develop strokes that could be minor as well as life-threatening. There was also an element of cost involved here, as there is a significant difference between the cost incurred for the flow diverter versus surgical bypass. The need for recurrent follow-up and revision treatment is a point worth mentioning here, as this patient belonged to a location that was difficult to access in case of an emergency, and also the medical facilities at her place were not that advanced to manage any such problematic situation that could arise. Points in favor of a surgical bypass option was that it ensures that there is an immediate decompression, there is an immediate symptom relief, and absolute reduction in chances of a rupture. There is less requirement of doing repeated angiograms and repeat treatment. It's indeed cost effective, and since the antiplatelet agents needn't need to be continued for a lifelong, it is associated with decreased to absent risk of post-treatment bleed and stroke. However, the surgical option is not without significant risks. It is a relatively invasive option with perioperative morbidity of around 20%, and there is a significant risk to life as well as function. It is associated with longer length of stay, pain, and blood loss. And since this patient is a young female, there is always concern about the scar morbidity and cosmesis. The strategy was multi-stage deployed in this patient. The stage 1 was to have an insurance in place, that is, to do a high flow bypass from the left external carotid artery to the middle cerebral artery using a left radial artery interposition graft under SSCP and MAP monitoring. Awake surgery was not considered during this stage. The second stage was a period of recovery and evaluation where the bypass would be evaluated and its function assessed very strictly. The stage 3 is when the bypass is shown to be effective and working all right, then to proceed with a repeat balloon occlusion test, and if positive, to perform an endovascular occlusion of the internal carotid artery. According to our experience, and also that has been described in the literature, the large majority of these bypasses, they do fail in the first 72 hours. So we wanted to give a cooling period of about 4 to 5 days where we demonstrate a very nice functioning bypass in the place. Some of the key points: the left radial artery was evaluated with the help of a Doppler, and its collateral and the sufficiency of the ulnar artery was documented. This surgery was performed with collaboration with a vascular surgeon, and to increase the surgical ergonomics and efficiency, 3 teams were deployed to do this surgery. One team was geared to harvest the radial artery and close the wound. The second team was to expose the blood vessels in the neck and to perform the bypass in the neck. And the third team worked at the cranial end. Anesthesia-wise, the mean was kept about 10% above the mean. Normal volemia was ensured, hyperventilation was avoided, and temperature and blood gas was regulated. A loading dose of heparin 1000 units was administered just at the beginning of the craniotomy, and this was followed by low molecular weight for 3 days, and later on this was bridged over to tablet aspirin 75 mg once daily. Please do let me know in your comments that what kind of anticoagulation strategy do you employ for doing a bypass. So the key surgical steps have been divided into 3 phases. The first phase is from step 1 to step 4, where the radial artery is harvested, the neck is exposed, a left pterional flap is created, the radial artery is tunneled within the skin under the subcutaneous plane from the neck onto the cranial side. The next phase involves preparation of the cranial end of the graft, the dural opening, the sylvian dissection, the recipient artery preparation, and then doing a radial artery to M3 end to side anastomosis. The last phase involves performing the anastomosis in the neck and then closure at all the points with careful consideration to the graft. The following video, you will see steps 5 until 9. The rest of the steps have been done without a recording. So this shows that the adventitia around the radial artery is dissected. The dura is now being opened. Small puncture holes are made to have the CSF released. that the brain can become lax, and gentle meticulous dissection of sylvian fissure is done to expose the underlying M3 and M4 branches. Very few small branches which comes into the way can be taken. This enables placement of temporary clips on the either side of the recipient site. Temporary clips that is being placed across the recipient site. Markings are made on the graft as well as the recipient. Arteriotomy is done with the help of a needle and then extended with a micro scissors in both the directions. A lumen of the recipient is noted. This is irrigated well with saline, and then the bypass is started with anchoring stitch at around 12 o'clock position and another one at 6 o'clock position. On the top right corner of the screen, you will notice the location of the stitches that are being placed. This is the 6 o'clock anchoring stitch. It is very important to keep the area very clean and tidy. Ensure good visualization. The magnification of the microscope is changed from high to low, and this is done frequently. The high magnification is utilized to pass the suture onto the wall of the graft and the recipient. The low magnification is when the sutures are being tied together. This is the back wall part of the anastomosis, and this portion of the bypass is initially completed. It's very important to keep an eye on the needle. Both the needle and the suture material, they are very tiny and both can get lost, and there are reports of this needle getting lost in the intracranial cavity. This is the last stitch that is being taken onto the back wall, roughly around 7 o'clock position. This is the final stitch on the back wall. The lumen of the graft is washed with some saline, and the bypass is further carried on onto the front wall. In this area, what we have done is we have taken few loops across the anterior wall, and then these loops in the end, they are cut and then they are stitched simultaneously. This ensures speedy execution of the bypass. So these are the loops that are being put. This is the last stitch, which is coming on to roughly around 5 o'clock position. You see there are loops hanging out from there. These loops would be cut. Yeah, so this is the tie. So Sequentially, all the ties are completed, and wherever there is a gap between two stitches, an additional stitch is made there. There is some backflow from the proximal portion of the recipient, which is absolutely fine. So there is a one area which was thought to be having a gap, which is close to the 12 o'clock position, and this is being taken care of with the help of a stitch as seen in this video. And this happens to be the last stitch of the bypass. As this is being done, you will notice that there is a retrograde filling into the graft from the proximal MCA, which is a good sign, and there is some bleeding also, which shows that the lumen is patent. And this is the completion of the bypass. The graft is being filled with the retrograde flow. The temporary clips are now being removed sequentially, and a little bit of oozing that is perfectly okay, and which is good in fact. And as this is being done, the graft becomes completely pulsatile, which is a very good sign. This is the end of the bypass, the cranial portion. It's followed by a anastomosis in the neck, which is performed by the vascular surgeon, where the graft is stitched to the external carotid artery in end to side manner with 80-proline. The intrafluorescein angiography shows a very good functioning bypass. The patient woke up without deficits, and she maintained that until the next phase. 5 days later, a balloon occlusion test was done, which she passed, and a selective DSA showed good flow into the middle cerebral artery and anterior cerebral artery, and no neurological compromise. Once this was established, the parent vessel, which is the internal carotid artery, was occluded in an endovascular manner with the help of coils. This is the angiogram which was done 5 days post op. You can see the clips, and which shows a functioning bypass. This is the external carotid artery, and the bypass is getting the blood from the ECA and is supplying onto the middle cerebral artery. The patient was on follow up, patient was doing well, and this is again shows that the filling of MCA with the bypass. This is the vertebral artery run. This is again the angio that was done 2 years later, which shows a functioning bypass. And with this 2 years, patient is remaining clinically stable. A vision has normalized. She is being continued on aspirin 75 milligram, and we have advised to stop this aspirin when she is planning to get pregnant. Additionally, we also did a SPECT study with acetozolamide challenge, and that also showed that perfusion to be absolutely normal. This is the baseline study, and this is the challenge study, and that shows no element of misery perfusion. Thank you for watching. Please to share and subscribe.